possible to cover everything, okay? So, oops. Can I?
You use the arrows, go down, and there'll be arrows to move forward and backward. You use those arrows to move
I don't
forward.
think the arrow is letting me do it because I'm using a Mac.
Saming, I'm using the Mac as well. So when you put your cursor on there in the left-hand side, you will see the arrows, which will allow you to go front and back.
It's not letting me do the cursor.
Do whatever is.
Anyway, I just need to do whatever I need. At least I've got a presentation today. So, so RCOA curriculum, as what Yahya was saying, and it's going to change in 2021, which actually making it quite fluffy, really. But this is the current curriculum, okay? And so if you get asked a question in a Viva about acute pain, you have to talk about multimodal analgesia. And if you talk about chronic pain, please talk about the catchphrase of MVP approach as well. Okay, so WHO analgesic ladder, I'm sure you've all familiar with that. So you increase the amount of analgesic as the pain is persisting or increasing. And then for cancer pain, you give the medications on the clock rather than on demand. And adjuvant medicines mean that these medicines have primary indication other than for pain management, but have some analgesic properties in some painful conditions. And they may be administered with analgesics to enhance pain relief. And then I think you might have to also be aware of the concept of Oxford Analgesic League Table for acute pain. So they've got a number to treat concept, so which is the number of patients needed to treat for 50% pain relief compared to control. So if the NNT is higher, then the drug is less effective. So if you look at the top of the list, it's probably not too clear, but it's a sort of paracetamol 1 gram plus ibuprofen 400 milligrams. Okay, so acute pain medicines are such as the non-opioid simple analgesics, which is paracetamol and nonsteroidals, and then you've got choice of opioids. You've also got choice of local anesthetics, either topical, local, or regional. And then there will be other adjuvants such as anti-neuropathic agents, so antidepressants, anticonvulsants, and others such as Antanox, ketamine, clonidine. And then chronic pain medications, so all of the above, plus you could do steroids, but obviously there's some change in guidance because of COVID, so you can only, it's advised that you give it only if it's suspected acute inflammation in chronic pain. There are other medications such as capsaicin, cannabinoids, or muscle relaxants. And then for cancer pain is a little even more complicated. So it's all of the above plus neurolytic medications, and there are some specific medications. For example, for bone pain, you can have choice of calcitonin or bisphosphonate, or pain from bowel obstruction such as octreotide and anticholinergics. And there's also use of bisphosphonates in early CRPS in the form of single dose of pamidronate. I think all of these are quite specialized, so it's unlikely that you get asked this for your basic and intermediate exams. So we start off with paracetamol. So mechanism of action, not very clear, as everybody knows. So if you look at the BJA education, there are 3 proposed mechanisms. So it could either be prostaglandin inhibition in the brain, or it could be from endocannabinoid enhancement. Oops. And there's also another pathway to say that potentially it could be serotonin pathway activation. So some of the action of paracetamol could be inhibited by your 5-HT3 antagonist, your ondansetron. Okay, so I think MHRA alert 2010, so there was a change in paracetamol dose, a little bit lower dose than previously because of paracetamol toxicity. I think all of you will be, you know, young enough to not know the previous higher dose. So I don't think there should be any problems with the dosing nowadays. So in terms of pharmacokinetics, it's mainly absorbed in a small bowel, and then it's metabolized in the liver by glucuronidation and sulfation to non-toxic conjugates. There's also a small amount oxidized by cytochrome P450 into your non-acetyl D-benzoquinolamine, which is conjugated with glutathione, which is excreted renally. The only thing to be aware of is, you know, accidental overdose, because there are lots of different formulations that have paracetamol. So it's cocodamol, coldidromol, should be Tramoset rather than Tramoat, and various cold medications. So if you look at this metabolism flow chart, so you can see that most of the metabolism is via conjugation, and then there's a very, 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 very small proportion which gets oxidated with the cytochrome P450 system. So in a normal state, if there's enough glutathione, then it gets conjugated and excreted. But if glutathione is depleted, then you get toxic metabolite, and which leads to cell death in the liver and kidney. Sometimes, if you're doing an MCQ, they might ask what type of liver injury, so that's the answer to that. And then the treatment obviously is with N-acetylcysteine, which you have to use a normogram. Okay, and then we go to non-steroidals. So I'm afraid you're going to have to memorize the arachidonic acid pathway, where you know, your arachidonic acid is transformed into different prostaglandins. So you have as a constitutive and inducible as well, which happens when there is inflammation, and also in some cancers. So side effects of non-steroidals, that's from the imbalance of all your different cytokines. So for your cardiovascular risk is inhibition of COX-2 leading to inhibition of prostacyclin. And creating a prothrombotic state. Renal risk, non-steroidals inhibiting PGE2 and PGI, leading to sodium retention, reduced renal blood flow, and renal failure. In terms of bone healing and anastomotic leak, there is actually no conclusive evidence for absolute contraindication, although some of the surgeons tell us that there is. In terms of COVID-19, obviously there's some NHS England statement to say that there's currently no evidence to say that the acute use causes increased risk of developing COVID-19 or more severe disease. But obviously there are other side effects with non-steroidals. So they've just asked you to use the lowest effective dose for shortest period of time. That's for your acute pain. The advice for chronic pain is to continue, but need to be reassessed if the patients catch COVID. So, but then again, you know, if you look a little bit further, there's a Liberate study which actually is going to examine the lipid ibuprofen versus standard care for respiratory failure due to COVID-19. So, you know, it's so non-steroidal isn't entirely dangerous. So in terms of opioid, there are various different classifications. Such as mode of synthesis. So you can have natural occurring compounds or semi-synthetic or synthetic compounds. As also by degree of pain relief. So you can have weak opioids or strong opioids. There's also, you can also classify opioids by degree of receptor affinity. So you can have agonist, antagonist, partial agonist. I suppose from this point of view, you know, sometimes they might ask you in the exam to draw your dose response curve. So I've sort of put in some examples because you might be asked to draw it out in your viva. So that's you know, your full agonist, and then full agonist plus antagonist sort of moves to the right side, and then buprenorphine is your partial agonist, and then you know, you have another curve if you have a slightly bigger dose of antagonist. And then another system of classification is by chemical structure. I think for the basic and intermediate, I think you just need to know the first two classifications really. And also if you look at E-meds, it'll probably tell you what class of opioid these medications are when you're trying to prescribe that on your electronic prescribing. So in terms of receptor, you have mu, delta, and kappa, and it's everywhere, but a lot of it is actually in your descending modulatory pathway and also in the dorsal horn of the spinal cord. So there are different actions related to the activation of different opioid receptors. In terms of mode of action, when your opioid binds to the mu receptor, all your opioid receptors are inhibitory G protein coupled receptors. And the actions are mainly to close two different types of ion channels. So you have your calcium channel, voltage sensitive calcium channel in the presynaptic membrane, and that actually decreases neurotransmitter release. And then at the same time, there's also activation of the potassium channel in the postsynaptic membrane that leads to membrane hyperpolarization and hence less action potential generated. There's also decrease in cyclic AMP production, and that also decreases the neurotransmitted release. This little table is just to talk about you know, the other G protein coupled receptors that you might have to remember for your exam. So you have so in terms of if you get asked about side effects, don't forget to classify. That's part of your exam techniques. So if there's you know, what do you do in terms of different side effects? So for example, constipation, you can try to give some laxatives. Dry mouth, you can try to do fluid intake or artificial saliva, nausea, vomiting, and so on and so forth. You also need to note that some of the side effects are you know, long-lasting. You don't actually get tolerant to that even on prolonged use of opioids. Just beware of side effect in pregnancy and breastfeeding. In terms of DVLA, it's actually now an offense to drive if your blood opioid exceeds a specified amount. So it's worthwhile just to tell the patients about that. Other potential long-term side effects of opioids are lowered immunity. There's also suppression of hypothalamus pituitary adrenal communication. There's also a state of opioid-induced hyperalgesia. So there's actually become more sensitive to pain than having pain relief with high-dose opioids long-term. So as Opioid Aware campaign, if you haven't seen this, so it says that opioids are very good for acute pain and end of life, but doesn't actually work that well in chronic pain. So the chronic pain patients need to be assessed thoroughly and stop it if they don't need it. The other thing you need to remember also is your opioid morphine equivalents. So everything, all the other opioids get converted to morphine. So you need to know the exchange rate for that. Just one of those few things that you need to memorize. And then don't forget the patches. So your blueprint morphine patch, 5 micrograms per hour is about morphine of 12 milligrams per day. And fentanyl 12 mics is about 45 milligrams of morphine per day. So in terms of codeine, I'm sure you all are aware of this. There's problems with people who can't metabolize it, and also the ultra-fast metabolizers. Problem with ultra-fast metabolizers is they'll have loads and loads of different side effects with codeine. So in a normal state, most of it is converted to glucuronide and then eliminated by the kidney, but small percentage is metabolized by the cytochrome P450 system, and that causes problems.
Two more minutes.
Sorry?
2 more minutes. We're running behind the time.
Oh, okay.
I'll cover a few of those slides as well. I've got some more.
Yeah. So dihydrocodeine is a little bit better because it doesn't rely on your cytochrome P450 system. And then this is morphine, so it's only 30% bioavailable. Duration of action is about 3 hours, and you have your inactive metabolite and your active metabolite, which is morphine 6-glucuronide, mainly excreted in the urine, small amount in bile. And then there are other opioids with other additional actions. So your tramadol has serotonin and noradrenaline. Tapentadol has noradrenaline reuptake, so on and so forth. Just have to be careful with your MAO inhibitor and phenylpiperidine because of problems with potential exacerbating serotonin syndrome. And then compare and contrast. Sometimes you might get asked in your exam. Please read the slide when you open it in your free time. And then transdermal drug delivery. So you can have either a matrix system where they all mixed up together, or a reservoir patch where the rate control is by the membrane. Antidepressants and anticonvulsants are mainly used for neuropathic pain. And I think you'll have a little bit more of this in the next talk. But you need to know that antidepressants' main mechanism of action is to increase levels of noradrenaline and serotonin, which enhance the descending inhibition. So you have examples of tricyclics, serotonin, noradrenaline reuptake inhibitors, SSRI as well, but that's not usually effective in neuropathic pain. And And then there's side effects of that. It takes a little while for antidepressants to work, so it could either be days or weeks, and it's smaller doses than depression dose. But there are problems with anticholinergic, antihistamine, and antiadrenergic side effects.
Manish is covering part of that, so I think you'll probably just have to skip because we'll have to go on to the next talk.
Okay.
Right.
So do I have to talk about anticonvulsants as well?
He's covering part of that. So basically, you've covered majority of the stuff. Acute pain stuff is covered. So
okay.
Skip through. Sorry, I think you're just keeping to the time.
Yep. So your gabapentinoids, I think that the thing that you need to remember is that it blocks the calcium channel, and it excreted unchanged in kidneys. So if you have renal failure, you just need to be very, very careful. And then capsaicin, as Mahesh said, depletes the amount of substance P, but also there are also other mechanisms involved which are proposed, so like defunctionalization of the nociceptor fibers. But I think if you talk about the depletion of substance P, I think that should be okay for your exam. And then other bits are preemptive and preventive analgesia. So this preemptive is to start before incision or injury, but might not be possible if you have trauma. And then preventive is just anytime before the onset of pain to prevent chronic pain. So you just need to remember that for your exam. And then don't forget to read about local anesthetics. Okay, I think that's all I have to say. Anybody has any questions?
I think we have one question, Yee. Somebody's asking, I think Anthony's asking, is there a meaningful interaction between paracetamol and recreational cannabis use? You propose one mechanism for paracetamol being reduced reuptake. I don't see any interaction. I've never come across.
I've never come across that. I mean, a lot of our patients are on, cannabis for fun, and it doesn't seem to have any problems. And also, like even patients with liver problems, your liver has to be very, very depleted to experience from paracetamol toxicity. I mean, even in the liver transplant unit, they still give paracetamol to patients, but very carefully.
You can start uploading your slides. So I think take-home message for the pharmacology, I think for your basic and intermediate module, you all work as anesthetists. You should know the pharmacology of opioids in and out, because there's no mercy if you're getting question on that in the viva. You can't say, I don't know pharmacology of opioids. So I think it's very important, because we use it day in, day out. The drugs that you use, like fentanyl, morphine, remifentanil, you should know in and out of the pharmacology of opioids. Okay, paracetamol, you need to know about that. Anti-inflammatories, now we are using lesser, but things like IV paracoxib, IV diclofenac, these were the things that are still used throughout different parts of the UK. So even though we don't use them that much, we use ketorolac as a part of our sort of IV non-steroidal anti-inflammatory drug. But I think you guys need to know the pharmacology of local anesthetics, definitely, because you are using local anesthetics as a part of your day-to-day work, in epidural space, spinal and, wound infiltration catheters. You need to know about the local anesthetic. And in terms of when you do chronic pain clinics, you will come across these drugs that we use, antidepressants, as Yee mentioned, amitriptyline, nortriptyline, and other drugs we use most commonly are gabapentin, pregabalin. And she was mentioning gabapentin and pregabalin. They don't work, as word says, gabapentin doesn't work on the gabapentinoid, GABA receptors. It reduces the calcium release and reduces the neurotransmitter release. And that's how it works. So it reduces the neuronal excitability. Okay, Pradeep, are you still there?